Hello. Hello, welcome. My name is Mike Anglesby. I'm a professor of surgery at the University of Michigan, and the title of my session is Acute Prescribing Guidelines. So these are the objectives. I want to describe the perioperative workflow and the roles of various stakeholders, and how you as a practitioner are key to our efforts to kind of combat the opioid epidemic. Identify best practices for acute prescribing, and describe the implications of using these best practices. Essentially, how can we as medical assistants, dental hygienists, nurses, physicians, physician assistants, PAs, all of us that care for our patients, how can we be part of the solution for this devastating epidemic? So the thing I'm asked most often is, how can I improve care? How can I be part of the solution? We all work in this kind of overwhelming system of care, and it can be intimidating to ponder how it can be part of it. And this is the conceptual model. I won't bore you with this, but essentially there's three components. You got to have some data. You got to at least collect the data on a couple of your patients, or at least refer to the literature. You have to get everyone to care. I got into this problem because as a transplant surgeon, I saw the devastating impact of the opioid epidemic, where we were doing literally many-fold more transplants because so many people had overdosed. We had all these extra new source of organs for transplantation, which is a devastating kind of observation for the public health. But most importantly, you have to kind of give a pathway for change. So no one's going to change if you don't make it easy. So this is how you have to fix the problem. And we all work in these systems of care, and as we can see, this is essentially the workflow of the individuals who have simple operations. So this is, I do believe, is children who have outpatient surgery at my institution. And just look, there's literally 50 or 75 individuals that engage with these patients and their families regarding their pain care. And as you create this pediatric pain task force, you can see how humbling it is that we have to engage with all of these people to understand what they say, what their expertise has to inform changing the process. And you just have to consider everyone, which makes change hard. But if you can get everyone to care, and we all care about the patients, it can kind of start rolling downhill. And I'll give you some examples of how we had some success. So we got started on this problem probably 3 or 4 years ago at our institution, where actually a medical student kind of got interested in the concept of people who have surgery for normal problems and are then leave the surgical event stuck on opioids. So we think this is a key kind of root cause to the opioid epidemic. People have routine surgical care. We give them too many pills. They keep taking them even after the surgery is over, and they essentially then move on to not only chronic opioid use, but misuse, addiction, and then potentially overdose. So this is a little study that a medical student did that I think illustrates kind of a pretty effective way that we fix this problem at our institution. So this slide shows patients who had their gallbladder removed at the University of Michigan. And on the right is the percent of, on the left is the percent of prescriptions, and on the other axis is how many pills we gave. So Norco is kind of a common opioid. It's combined with acetaminophen for postoperative pain. It's like Vicodin. Has other names. But anyway, you can see the people who write for opioids after surgery, elective outpatient surgery, this is on healthy people, they got somewhere between 10 and 120 pills. Just kind of for no rhyme or reason. So you can kind of see here most of the prescriptions in here. Then we called all these patients. I think it was about 200 or 300 patients. We asked them, how many pills can you take? How many pills did you take? And as you can see, there's this big mismatch between how many pills we gave patients and how many pills patients took. And certainly it became clear very quickly that we were overprescribing for pretty much all of our patients. And they were having large numbers of excess pills in their homes, that really these excess pills get in our communities and they really fuel the opioid epidemic. Now, some patients take all the pills you give them. no matter what. If you give them 3 pills or you give them 100 pills, they're going to take all their pills. And those are another set of patients that we have to worry about. We have to have a frank discussion before surgery. But the vast majority of patients, at least in this cohort, had lots of excess pills. So what we did is that instead of giving 45 pills, say let's give, and by the way, the patient on average are taking 6. We started giving them 15 pills. And as we started giving them 15 pills, we noticed patients now were only taking 4. And what we realized is that still this 3 or 4% of patients are going to call for refills no matter how many pills you give them. And our refill rates did not go up. Patients took fewer pills. But I think most importantly, despite the fact that we gave many-fold fewer pills, patients reported their pain care just as good. And the reason this is that we talked about their pain. We set expectations. Surgery hurts. We care a lot about you. This is the plan, so to speak. Acetaminophen and ibuprofen around the clock, opioid pills only for breakthrough pain, and you should be off your opioids in a day or 2. So fueled by this observation, we set up a network across our entire state in Michigan to try to understand what is the appropriate amount of pills to give after surgical care. And these are the numbers. So you can see cholecystectomy now in the state of Michigan is down to 10 pills. Other procedures like dental extraction, we suggest no pills. These recommendations attempt to right-size opioid prescribing so patients get the pain medicines they need, but they aren't left with a lot of leftover pills. And patients who are vulnerable to chronic opioid use and addiction aren't given the extra risk of a big bottle of pills that can really lead them into chronic use. So we took our opioid prescribing recommendations across the state, across all the hospitals in the state of Michigan, and we did our best to kind of implement them with partnership for our private payers, state of Michigan, and all the hospitals across the state. And we basically said, for these procedures, this is how many pills we should give. And we had data using the conceptual framework I talked about in the beginning. We had data. We built an emotional case. People cared about this problem in our state because the epidemic was really devastating in our state. And we gave a pathway for change, which is essentially right for this many pills. And the brown line shows how the opioid prescribing changed across all the hospitals that do major operations in the state. As you see there, it went from over 200 oral morphine equivalents to now it's well less than 100. So it went down by 50%. So the bottom line is patients were getting half as many pills as they were. But most importantly, if you look at these other lines, which measure things like the pain score, regret about surgery, quality of life, and patient satisfaction, they were unchanged, if not even improved a little bit. So we were able to write for fewer pills while at the same time doing just as good, if not even better care for our patients. So that, I think, is why we as caregivers are absolutely critical to combat the opioid epidemic and to fix the problem of overprescribing. So I think when I talk to patients now, I have become much more mature in how I care for their pain. And I had a patient recently who I did a liver transplant on, and he had struggled with chronic pain before the transplant. He struggled significantly afterwards. And I literally just saw him like 3 days ago, and we kind of said goodbye, meaning he's going to move back to his regular providers after kind of surgery. So it's been about 3 months since his transplant. And we talked a lot about his pain and how opioids really are not the solution long-term for his pain. We were able to wean him off his opioids after surgery, and he's proud of that, but he still is struggling, and we have hooked him in with the best care within his community so that he can get all the pain care he needs so he can flourish after his operation. We didn't essentially leave him on opioids without care, without attention, and put him at risk for overuse, addiction, and then potentially overdose. So this is how I cared for that man. I said, Mr. H, I care for you. You know that. And the guidelines for how many pills we should give you after liver transplant aren't going to work for you. You need slightly different care. But for almost all my other patients, the guidelines work well. I set expectations for Mr. H. This is how much it's going to hurt. Most patients are off their opioids within a week. For you, this is the plan. We worked heavily for non-opioid adjuncts. I don't think just other pills are the solution here. There's all kinds of other opportunities to do best pain care that are non-medication based. And we worked with a lot of those with this gentleman. We talk a lot about disposal education. So if you have leftover pills, how critical it is to get them out of your home because they're not safe to leave in your home. And for this individual, we had very close follow-up where we talked to him frequently, made sure that he was thriving, so that he was not at risk for kind of going off the rails, so to speak, after surgical care. So anyway, I think this represents best pain care. I think as I've become more knowledgeable about the epidemic, I'm certainly not an expert in the pain care, but I've changed the way I talk to patients about pain, and most importantly, all the members of my team also kind of say the same things to our patients, so there's a consistent message, and that's absolutely critical. So I really appreciate your time, and hopefully this will help you do better care for your patients.